Coming to the anchor balloon techniques, there are 4 types. One is the coaxial anchoring, distal anchoring, side branch anchoring, and balloon anchoring inside the guide catheter. So coming to the coaxial anchoring, here over the wire, a balloon is kept inflated proximal to the lesion, and this improves the penetration capacity of the guide wire. As seen in this case, who has an LED CTO, initial attempts were made to cross the LED anti-gradely with a fine cross catheter backup. A field XT was used, and it was not going anti-gradely, it was going subintimally, as evident from the retrograde injection. So the next attempt was to go retrogradely with a cyan blue wire, and the microcatheter was not crossing. Hence, though we could reach the distal cap, the wire was kept as a landmark for reattempt anti-gradely. So here again, the attempts were made to cross anti-gradely with Fielder XT and Miracle 6. It was not getting advanced, hence we changed it to a 1.2510 Artemis balloon. And again, it was backing off. Now the balloon was kept inflated. And since we were sure that we were in the right track with all the, the landmark in the distal part, we inflated the balloon and confidently crossed the lesion anti-gradely. So with this coaxial anchoring, we could cross the wire anti-gradely and completed the angioplasty with a very good successful result. So coming to the distal anchoring, this is a simple technique which two wires are used. Over one wire, a balloon is kept inflated distally, which traps the other wire, and you can deliver balloons, stents anti-gradely comfortably. This is a case where RCA has long lesion. Initial attempts were made to predilate the lesion, and the stents could not be taken inside conveniently. Hence, a balloon is kept distally inflated, which traps the another guide wire, over which a long stent has been taken inside, and we completed the procedure. Now, side branch anchoring, which we usually use here, if it is an RCA, conus branch or RB branch is used, or if in LAD a diagonal branch or a circumflex and OM branch. A small balloon of 1.5 to 2 mm balloon is inflated at 6 to 8 atmosphere in the side branch. Care should be taken not to damage the side branch. And with this anchoring, we can take balloons and stents comfortably inside. This is a pictorial representation of the side branch anchoring. Here, initial attempts to cross the lesion anti-gradely was not successful. Hence, a wire was placed in the conus branch, and a 210 balloon was kept inflated. And we could take the balloon comfortably inside and the stent as well, and completed the procedure without much difficulty. So the limitation is we should be very careful not to damage the side branch. Now, balloon anchoring inside the catheter, this is done when we are not able to, like if you use a microcatheter, you have to remove it. To avoid a docking, you can just keep the balloon inflated at the distal visible part of the guide catheter. Usually a 2 mm balloon is used, inflated at 6 to 8 atmosphere, and the microcatheter can be comfortably removed, and we can complete the procedure. Thank you.